important and very vital. Now, before we talk about how we manage the neck, I'll just take you through the TNM classification which we follow, both clinicians also and the pathologists also. And the end stage, how it is staged, the neck. So this is a N0 neck. So you don't have any neck nodes which are.
This is decided by CT scan or PET scan.
So yes. So this TNM classification or the staging is a clinico-radiological staging. So both clinical examination added with a radiological.
Because in cervical lesion you get lot of non-specific lymph nodes.
So that is what I am telling. So the thing is, you have a clinical examination of the neck and a radiological examination. So when you ask for a radiological examination of the neck, the three most important examination is sonography, ultrasonography of the neck, CT scan of the neck and MRI of the neck. So one of these modalities we would ask for. Now, taking your question, most of the necks will have some infective etiology, but there are criteria radiologically to differentiate a reactive node or infective node from a metastatic. So sometimes when we deal with the radiology of the oral cancer, so there is you have to have a hilum which is there, the extranodal, the capsule should be intact. So it's a oblong node, the normal nodes. This is a rounded node. So all this, the ecosity of the node, all these features will tell us whether the node is a reactive infective node or a metastatic node. Okay, so but this staging is a clinico-radiological staging. So when we write say T2, N1, M0, so T2 is the size of the tumor, N1 is the node which is there. So this N0 is no clinico-radiological node which is visible or palpable in the neck. N1 is a node which is there in the ipsilateral neck. Ipsilateral meaning the primary is on the right side of the oral cavity. You have a neck node which is in the ipsilateral neck. Now this N1 node is less than 3 cm in size without any extranodal extension. So a node which is less than 3 cm in size, ipsilateral neck, without extranodal extension is staged as N1 neck. N2 you have N2A, N2B, N2C. N2A is a node which is 3 to 6 cm in size without any extranodal. Multiple nodes, but none of the node is more than 6 cm in size, all on the same side, the ipsilateral neck. This is N2B. N2C is a contralateral node also appears. So lesions which are reaching the midline or crossing the midline will have a contralateral node also. So but none of these nodes again are more than 6 cm in size. So N2 is N2 is nodes which are less than 6 cm in size. N2A is single node, N2B is multiple nodes, and N2C is contralateral.
So lesion which does not cross midline will not have contralateral node?
Most of the times they will not have.
Most of the times.
Most of them. But if the lesion is a big lesion, ipsilateral, not crossing the midline, say a T4 tumor involving the skin, fungating out of the skin, might have a contralateral node, even if the lesion is not crossing the midline. N3 is N3A and N3B. N3A is a node which is more than 6 cm in size, but the capsule is intact, there is no extranodal spread. And N3B is any size node which is having an extra capsular or an extranodal extension. So this is how we would stage the nodal neck.
So all these metastatized lymph nodes are always hard in consistency clinically, or they can be different?
They can be different, but most of them are formed to hard in consistency. They are not soft as we palpate most of the patients who come with some infection in the tonsil or oral cavity or dental disc. Most of these nodes are soft, and they would go with 1 week of antibiotic and you take care of that infective etiology, they will go. But these are firm, solid nodes. So hope this is clear, the staging part. Now apart from the staging part, we clinicians, head and neck clinicians, have these levels of nodes also. Now why this levels of node is because in our anatomy we study submental node, submandibular, jugulodigastric, middle jugular nodes. But in our this thing, to have a uniform classification, what we have done is we have divided the neck into nodal levels. So if you talk about level 1, it is submental and submandibular nodes. And this level, most of the times, the primary you will be able to find in the lower lip, the anterior tongue, floor of mouth, gingiva and buccal mucosa. So all these tumors, primary tumors in this area of the oral cavity will drain into this level 1 nodes, that is submental and submandibular. Level 2 area would drain the oral cavity, mainly the posterior tongue and the buccal mucosa, the pharynx and the larynx. So this level 2 is the upper jugulodigastric nodes. So this again is a very important level when you are dealing with lesions of the tongue. So most of the tongue malignancies would drain into level 2, which is the upper jugulodigastric nodes. Level 3 is the middle jugular nodes, and the areas which drain into this level is nasopharynx, oropharynx, oral cavity, hypopharynx and larynx. Most of these nodes will drain into level 3. Inferior jugular nodes, the hypopharynx drains into it, the subglottic larynx, esophagus and the thyroid also. So this level, the lower jugular, the larynx, hypopharynx and the esophagus would drain into this level along with thyroid. Posterior triangle node is this level of nodes, and most of the skin lesions, the squamous cancers of the skin in the posterior part of the neck would drain into this level 5 node. Again, this level 5, most of the breast lesions also drain into this node. So if you have a breast malignancy and a level 5, most of the time it is considered inoperable, the breast lesion. So this level 5, the breast and the skin lesions of the posterior neck would drain here. Anterior compartment node is this level 6 node, and this is mainly involved again by the thyroid and lesions which are in the anterior larynx and the subglottis. So this is level 6. So this is how. So supraclavicular is this area, level 5. So this is what some would say supraclavicular, some would say posterior triangle, some would say inferior. So that is why this levels we have designed, so that it's a uniform this thing. When you say level 4 or level 5, you understand which side or the which exact area in the neck is involved. So this is how it is. The levels are decided.
This is not exclusive, right? This is general outline. Or these are exclusive one.
And I am not getting exclusive.
So in level 2, there won't be any other malignant nodes from the oral cavity or pharynx or larynx. Is it like that? Or it will be overlapping?
No. So if you have a level 2 node, most probably the primary you will find in this area.
So most probably, but
Yeah.
it's not exclusive.
No. So because see, when you say oral cavity malignancy, it will not, yes, it will just spread. So a buccal mucosa thing can go into the alveolus, it can go into the floor mouth, it can go into the tongue also. So when you have a lesion which is say T3 or T4, which is more than 4 centimeter in size, you can have nodes anywhere. But if you, because there are a lot of studies which are done on neck dissections in science. So when you operate say 1,000 cases of neck dissection and see the levels of lymph node which are positive and then compare it with the oral cavity primary, then you get this, okay. So there are a lot of studies, I'll go through that also in one of my slides.
So this is, if patient presents is group 2 and group 3 node, that means there is a extensive disease, oral cavity lesion with the extensive disease.
Correct.
If they simultaneously
Yes.
present with group
So
2.
see, what happens is most of the times when you have this node here, a single positive node in the neck means a stage 3 disease. Whenever there is a single positive node in the neck, it's a stage 3 disease. So for a neck node to come here, you will have to have a primary also of that size. Then only it will metastasize in the neck. That means that when you have these nodes which are positive, you will be able to clinically visualize the primary also. There is an entity as unknown primary with neck node. So that is a different entity altogether. So you have a neck node which is there, but you are not able to see any primary. So that's a different this thing. We will deal with it someday, some other day. But this is basically a rough this thing. When you have lymph nodes in these areas or at this levels, you have to search or look for the primary here. Now again, this is important in our group of patients because most of these patients are having some sort of mouth restriction or trismus, which is called oral submucosal fibrosis. So because of that long-standing pan masala mawa gudka, what happens is the mouth opening becomes restricted. So you are not able to examine the patient when the patient comes to you in the OPD. So clinical examination you will not be able to do. But when you have a level node here or here, at least you have that idea that the primary must be somewhere here. So you have to search for look for the primary in that area. So this is these levels are important in that way. They'll guide you where to search for the look for the primary.
The primary be occurred and
So that is what I am telling you. Occult primary with a neck node. So unknown primary with a neck node. Yeah. Now again, if you have a primary, if you have a neck node, things become easier to stage. But when the primary is a small primary, say a T1 lesion or a T2 lesion, then the management of neck is very important. So you have a small primary which is less than 2 cm in size on the tongue. So now the issue is whether to manage the neck or not, because it's a small primary. So there are studies which are done on the depth of invasion of the primary. So when you have a tumor which is say T1 or T2, a small tumor on the tongue, then you have to study the depth. So the risk of occult nodal metastasis. So in absence of clinico-radiological presence of the node, even if you do a neck dissection, there is a risk of occult. So there will be occult nodal metastasis which are not picked up clinically and radiologically. So if you assess the depth, if the depth is 2 centimeter, 2 millimeter or less, the chances of you getting a neck node is less than 10%. But if you have a thick tumor, say more than 8 millimeters, the chances of a neck node, occult neck node, is around 40%. And if you have something which is in between 2 to 8 millimeter, it is around 24%. So the depth of the primary lesion, when the lesion is T1 and T2, is very important when you have to address the neck or manage the neck. Understood?
means biopsy is compulsory.
Biopsy is a histopathological diagnosis.
Is compulsory.
So biopsy is something which will tell you if this is squamous cancer or this is some traumatic ulcer. Okay. Now, if the tumor is a squamous cancer, you have to deal with the primary. But at the same time, whether to address the neck, whether to do a neck dissection also is very important. So, for that, the depth is very important. So, for any tumor, most of the times, if it's a tongue tumor, we would always like or advise the MRI of the oral cavity because it will tell you the depth also of the tumor, the third dimension. So, by that, because in palpation, it is a subjective this thing, it is variable. What I will feel it is a thick tumor, you will feel no, it is not a thick tumor. So MRI will guide us about the third dimension or the depth of the tumor. Whether it is 4 millimeter, 5 millimeter, the MRI will give a rough estimate. And most of the time that will correlate with your final histopath also. Now look at this, the overall incidence of nodal metastasis. So this overall incidence of nodal metastasis when the tumor is thick is around 50%. And if you see the overall survival, it drops to around 60%. If you have a thick tumor with a node positive, it drops to around 60%, whereas a node negative neck, the survival is around 95%.
Now it is written as the patient's dead of
Yeah,
disease.
so this is not dead, it is survival. So around 60% and this is around 95%. So again, this stresses the need of addressing the neck and the importance of a neck node when you manage oral cancer patient. Now we also have looked at our data. So this is the depth of the tumor. These are the total number of cases, around 109. So according to the depth of the tumor in millimeters, 1, 2, 3, 4, 5 millimeters, these are the number of patients who had this depth of tumor. Number of cases with clinical radiographic N plus neck nodes. When the depth was say 4 millimeter, 3 patients had already positive neck nodes. This was clinical radiological. Now number of cases, all these patients we had done a neck dissection. So number of cases with occult metastasis were this. So if the depth is 4 millimeter, you start getting patients who will have the neck nodes which are positive. So if you see this, around 23% of our patients had nodes which were positive on the final histopath. This is our own data. Now coming on to the neck dissection. So what is a neck dissection is? It is clearance of all the lymph nodes or the lymphatic structures.
Sir, can you go back to the previous slide? Suppose in this 4 millimeter tumor depth, clinical radiographic nodes are 3 and occult is 1. So that one is not included in that 3, right? This one is different.
Correct.
Okay.
So this neck dissection, if you see, it is the removal of all the lymphatic structures along with non-lymphatic structures also. So this is the extent of neck dissection from the mandible up to the clavicle, the anterior border of the trapezius, and from here it is up to the midline. So this is the extent of a neck dissection when we say we have done or performed a neck dissection. Now there are different classifications of neck dissections which was not standardized until 1991. Now the most important neck dissection or the first neck dissection was a radical neck dissection, and all the other modifications of neck dissections are compared with this dissection. So radical neck dissection is removal of all lymphatic and non-lymphatic structures from the mandible to the clavicle, anterior border of the trapezius to the midline. And all these structures are lymph nodes, all the levels, the sternomastoid muscle, the spinal accessory nerve, and the internal jugular vein. And along with these two glands, one is the submandibular gland, the tail of the parotid. So this is something which is removed. So this if you send this thing, the radical neck dissection specimen, these are the structures which you will get in that neck dissection specimen. Now modifications to this radical neck dissection includes preservation of non-lymphatic structures, and if you preserve any one of these non-lymphatic structures, it is classified as a modified radical neck dissection. Any neck dissection that preserves one or more group of levels of lymph node is referred to as selective neck dissection. So when you have oral cavity cancer and you know if this cancer will only go and metastasize in level 1 to 3, then you just remove those levels and preserve level 4 and 5. So that is called selective neck dissection. And anything which is more than a radical neck dissection, you remove the carotid artery, you remove the skin over the neck, is called extended neck dissection. So this is a radical neck dissection specimen. So no sternocleidomastoid, no spinal accessory nerve, and no internal jugular vein. This is the carotid artery, and this is the cervical nerve roots. Now if you talk about the elective neck dissection, there are or modified neck dissection. This is type 1, type 2 and type 3. Type 3 is the spinal accessory nerve is preserved, the sternocleidomastoid muscle which we have retracted is preserved, and the internal jugular vein is preserved. So when you preserve all the three non-lymphatic structures, it is called type 3 modified neck dissection, and we also call this type of dissection as functional neck dissection because you are preserving the function of the neck. All the three important structures you are preserving, so it is type 3. Type 2 is you preserve the spinal accessory nerve and the internal jugular vein, you cut the sternocleidomastoid. And type 1 is you just preserve the internal jugular vein, you cut the spinal accessory nerve and the sternocleidomastoid. Selective neck dissection is lateral, anterior, posterolateral. Lateral is you don't touch the level 1 node, you remove level 2, 3 and 4, it is lateral. Level 6 you remove is anterior, and posterolateral is level 2, 3, 4 and 5. So this is selective neck dissection. Now why all this selective neck dissection, modified neck dissection came? Because radical neck dissection, the major problem with it is the morbidity, which is the shoulder syndrome. So what happens is there is pain in the upper arm, the side which you have operated, there is limited abduction, there is limited external rotation, there is disfigurement and drooping. So what happens is this thing comes here and there is a droop. So away the patient. When there is a radical neck dissection or you have not preserved the structures, this thing happens. So because of this, all this modification came up. Now most of the time the shoulder syndrome occurs because of the handling of the nerve. So in a modified neck dissection, you have to isolate the nerve, remove all the lymph nodes, which is posterior and anterior to the nerve. So handling of the nerve causes this shoulder syndrome, and along with this even the vascularity of the nerve is hampered. So if you have an intact anatomically preserved nerve without vascularity, so it is not functional. Again, when you do a supraomoid neck dissection, you have to remove the level 2B, which is posterior to the spinal accessory nerve, and when you do this, again you damage or you hamper the vascularity of the nerve, and because of that the shoulder syndrome occurs.
Any survival benefit?
Yes. We will go through that survival. I am just coming on it. So this is something which is the most important neck dissection or the minimum neck dissection we do whenever we address the neck. So supraomoid neck dissection is something to do with the omoid muscle. So this is the posterior belly of the posterior omoid muscle. So anything which is above it, so level 1, level 2 and level 3. So we remove this level 1, 2 and 3, and this is called a supraomoid neck dissection. So all the lymph nodes above the omoid muscle, the posterior omoid, we remove, and it is called supraomoid neck dissection. Now this is something which is important. This is Tata Memorial Hospital data which shows whenever you have a primary in the oral cavity without a neck node, most of the times the nodes are positive in this level 1, 2 and 3. So if you remove this 1, 2 and 3, 91% chances give you remove all the lymph nodes, which you feel that there will be occult disease in these lymph nodes. Only 4 or 5% of the lymph nodes would drain in this level 4 and 5. So this is supraomoid neck dissection. So remove level 1, 2 and 3, and it is mainly indicated when the risk of occult metastasis is around 20 to 30. When the neck is N0 or clinical radiologically there is no neck node which is positive. Now if you go to the management of neck, see if there is a node which is positive, it is a no-brainer. You have to address the neck and remove the neck nodes. Whether you are doing a modified neck dissection or a radical neck dissection will depend on the size of the node, whether it is stuck to the underlying structure. So that's a clinical radiological decision which you have. But for an N plus node, you have to do a neck dissection. It is something which is you don't have to use anything. So, but the most important and the challenging part is when you don't have a neck node. But there is a primary, you have to decide whether you are going to address the node or not. So this is based mainly on the risk of occult metastasis. If it is more than 25 to 30%, you have to address the neck. Okay. Most of the times you will be doing a elective neck dissection. Now coming to your question about the prognosis, about the survival advantage. So this is a landmark paper again coming from India in the New England Journal of Medicine in 2014, and this is by the Tata Hospital group. So what they did is they had two arms in the study. One arm got elective neck dissection. So day one, when you are addressing the primary, you are doing a neck dissection. And the other arm was the therapeutic surgery arm. So the total number of patients around 500, both the groups almost equal patients. Therapeutic surgery group is the patients were observed. So you have removed the primary, you have not addressed the neck. And this, you have removed the primary and addressed the neck. So this is elective treatment of the neck. Therapeutic meaning, whenever the neck node appears, you follow these patients. Whenever the neck node comes, you operate them. Okay, just to get an answer if what we are doing or whether the morbidity which we are giving to a patient is justified or not. So, simple study, two arms, elective neck dissection, no neck dissection. Tongue, majority of the cases, tongue 200, buccal mucosa and some floor of mouth. T1 and T2 almost equal number of patients. Baseline ultrasonography showed normal ultrasonography. Most of the patients had normal ultrasound. Some had indeterminate and some had suspicious. But most of the patients had a normal ultrasound, neck. If you look at the overall survival, the elective surgery group and the therapeutic arm, I'll come to this. If you look at the disease-free survival, the elective surgery arm and the therapeutic surgery arm. Now, if you read this, the overall and disease-free survival, at 3 years, the rate of overall survival was 80% in the elective surgery group and 67% in the therapeutic surgery group. There were 50 deaths in the elective surgery group and 79 deaths in the therapeutic surgery group. Now at 3 years, the disease-free survival was 70% in the elective surgery group and around 45% in the therapeutic surgery group. There were 81 and 146 recurrences in both the groups respectively. So look at this number, 81 and 146. Now the recurrence pattern also in the elective surgery group, neck done, neck not done, is nodal recurrence in 25, but if you see this, 108 patients out of that 250 patients had a neck node, which came up at a later stage. Local recurrences, the recurrence coming again in the primary 23%, 7%. Distant metastasis, second primary tumor. So if you analyze the results, there is an absolute overall survival benefit of 12.5% and a disease-free survival benefit of 23 or 24% if you compare both the arms. Now this is very important. This says that if you treat the neck in 8 patients, if you treat the neck in 8 patients, you are preventing the recurrence. You are preventing one death, and if you treat 4 patients, you are preventing one recurrence. So 8 patients, if I operate neck for a T1, T2 tumor, I prevent one death. And if I treat 4 patients neck, I prevent one recurrence or one relapse in the neck. So this is why addressing the neck is very important when you have a node negative neck, clinical and radiological. This is the
injustice to the others.
So that is what happened. They had to stop the trial in between because there were number of deaths increased and the recurrences increased. So this trial was stopped in between and these results were then published because of this only. Because the ethics committee was very listening. Yes, you have to stop this trial because there are deaths. In 8 patients whom you have not treated, there was one death because of the recurrence. So they had to stop the trial in between. Again, treatment of the neck surgically is important. But again, when you have the final histopath report, you have to treat the neck with radiotherapy also, and sometimes with radiotherapy and chemotherapy combined also. So when you give radiotherapy to the neck, when there is an N plus node at more than one level, these are the indications of adjuvant treatment, that is radiotherapy for the nodes. So any positive node more than one level, you have to give radiotherapy. If the node, single node is more than 3 centimeter in size, you have to give radiotherapy. If there is extranodal extension, only one indication in the node, you have to give radiotherapy and chemotherapy both. If you have residual neck disease, that is, if you have operated and you have left behind disease, microscopic or gross, you have to give radiotherapy. If there are nodes, 2 or more nodes positive, N plus, then also you give radiotherapy. So treatment of the neck after surgery is also very important. So when you have to give adjuvant therapy, primary tumors you will give. So you give radiotherapy to the primary, but if you have these indications, one of these, you treat the neck also. So you have to treat the neck also. So radiotherapists would say, this is the upper limit and this is the lower limit. So they treat from here to here. Obviously they contour it properly. It is not, everything is radiated. But these are the indications when you have to treat the neck when the
What who will decide? Not whether it's chemotherapy first or radiotherapy first.
In this case, this. So radiotherapy, if you say, this radiotherapy is around 36 sittings or 6,600 to 7,000. 6,000 and around 6,000 sittings of radios you have to give. Now this continues for 1.5 months. So So from Monday to Friday, 5 days a week. Saturday, Sunday is a holiday for the cancer cells also to grow and the machine also to take some rest. So 5 days a week is radiotherapy. Now when you add chemotherapy to this, it is one chemotherapy cycle in 1 week. So it is concomitant. It is not first chemotherapy, then radiotherapy. It is not first radiotherapy, it is simultaneous. So weekly one dose of chemotherapy, 5 cycles or 5 sittings of radiotherapy, Monday to Friday, one chemotherapy in 1 week. So 6 cycles of chemotherapy and 33 to 36 sittings of radiotherapy. So it is a very aggressive treatment. 1.5 to 2 months the treatment continues. If chemotherapy is added to radiotherapy, the toxicity also increases. But because you have these indications, positive surgical margin or extranodal extension, you have to give chemo. So that is over for now. Any other question?